upon Dr. Geeta Haripriya ma'am to chair the session. Over to you, ma'am. Madam is currently the medical director of Prashant Fertility Center, and she was awarded the prestigious Blue Ring Award for excellent work on fertility and diabetes, and she has been awarded the Fellow of Royal College of Obstetrics and Gynecologists in the September 2007. Madam, I request you to introduce our speaker, Manish Banker, sir. I welcome you, sir.
Good morning, everybody. We now move on to the next session, and the topic is endometrial receptivity, current concepts, and this by Dr. Manish Banker, who needs no introduction really. He's the medical director, Nova IVF Fertility, one of the largest IVF groups in India, and he was awarded the Dr. B.C. Roy Award by the Medical Council of India for the year 2017. He is the past president, Indian Society of Assisted Reproduction, 2012 to 14, and regional representative, International Committee for Monitoring ART, and senior associate editor, Journal of the Human Reproduction Sciences, member board of directors, Poseidon Group. I think it's one of the biggest honors. Member surveillance editorial board, IFFS. Member board of directors, Pacific Society of Pacific Rim Society of Reproductive Medicine, founder board member Aspire, and member draft committee for the ART Bill of India. And I think it's a long list of things which you have done, and really, really great. And you've not only been academic, but you've also been on a lot of boards and really high credentials. So over to you, Dr. Manish.
Thank you very much. At the outset, I would like to thank Dr. Sanjeeva and the SMART conference team for inviting me here. It's indeed a pleasure and a very different feeling for attending the first physical conference after nearly a gap of 2.5 years. So this is a first for me after a long time. The topic that I shall be speaking on is current concepts related to endometrial receptivity. And this is a very puzzling area because there are too many things involved when we look at the endometrium, from the simple histology with which everything began to the ultrasound, Doppler, hysteroscopy, and now we have the role of the transcriptomics, the secretomics, and the microbiometa. So let me take you through what is the understanding on all this. Now, assessment of the endometrium is an absolute essential component in assisted reproduction. And when we talk about assessment, the only question that a clinician needs an answer to is the endometrium adequate to proceed or not to proceed in that particular cycle? That is the only piece of information that is really relevant. But there are a lot of dilemmas because we still do not have concrete evidence on the effect of endometrial thickness on the outcomes. More importantly, how do you define a thin endometrium? And equally important, do we have any methods of improving the thickness or the receptivity? So let us start at the very beginning as to how do you measure the endometrium. So typically it is measured in the sagittal plane. We look at the endometrium, the thickest area across the spectrum from the stratum basalis to and the endometrial surface to the other side, and typically the endometrium is thickest at around 1 centimeters from the fundus. But there could be a lot of issues in carrying out these very simple measurements, either because of pathologies or because of the position of the uterus, and there are also a lot of inter and intra-observer variation. To compound this, we have the effect of the uterine contractions, and studies have shown that there could be changes in the thickness of between 3 to 4 millimeters in the presence or absence of contractions, and this is a huge difference. And in such instances, it is best to wait for a few moments for the contraction to pass off before you take the measurements. Now, if you look at literature, there are evidences for and against the role of endometrial thickness. The first paper concludes that when we look at the endometrial thickness, there are higher implantation rates and pregnancy rates when the endometrium is above 9 millimeters versus when the endometrium is 7 or 8. And there is another study which shows that the endometrial thickness in the pregnant and the non-pregnant group is exactly the same. So no precise cutoffs are there for predicting a pregnancy, but arbitrarily a figure of 7 millimeters is what everyone uses. But still, if you see, the pregnancies have been reported even at such low thicknesses of 4 millimeters. And the classic example is an ectopic pregnancy. I am sure the thickness of the tubal cavity can never be in 10s or 12 millimeter. So it is much more than the thickness. So some studies have shown that the endometrial thickness affects the pregnancy rate. Others have shown to the contrary. And it is because of this, there is no exact definition. However, in spite of all these controversies, measurement and assessment of endometrial thickness is an essential and an integral part of all fertility treatments. But if you look at all definitions, this is what everyone concludes, that a thickness of less than 7 or less than 8 on the day of the HCG trigger is what classifies as a thin endometrium. A bigger challenge then is, what is the incidence of this thin endometrium? How frequently do we see? And this is a large study, nearly 40,000 fresh and frozen embryo transfer cycles from the Canadian database. And we find that endometrium is less than 8 millimeters in about 12% and less than 7 in approximately 4%. But this is an underestimate. The actual incidence would be much higher, because this is the incidence in patients who proceeded with a procedure. If the cycles were cancelled, and I'm sure a lot of cycles would have been cancelled, the actual incidence of an endometrium being less than 7 millimeter would be significantly higher. But if you look at most publications, the incidence varies between 1 to 2.5. If we move to the wider area of general infertility treatment, including all ovulation inductions, then the incidence could vary from between 6 to 37 millimeters. Again, what we are looking at is incidence in one assisted reproductive treatment cycle. What is more important is the incidence of a persistently thin endometrium. Now, we have ourselves studied and published the effect of endometrial thickness on ART outcomes, and this is looking at ovum donation and frozen transfer cycles only. And what we found, that with every millimeter increase in thickness beyond 6 millimeters, there is an improvement in the clinical pregnancy, ongoing pregnancy and the live birth rates, but there is no difference in the abortion or ectopic pregnancy rates. We have also shown that the duration of estrogen before addition of progesterone is critical, and if this is less than 10 millimeters, the pregnancy rates are significantly lower as compared to when the endometrial or the estrogen priming is for more than 10 millimeters. So if you look at all this systematic review and meta-analysis, the conclusion is that use of endometrial thickness as a tool to decide on cycle cancellation, freezing of embryos, or refraining from further IVF treatment does not seem to be justified based on all current evidence. Now, this could be multifactorial, inflammatory, iatrogenic, so on and so forth, but the most important is that the endometrium is somehow inherently thin in some women without any appreciable cause, and this is the biggest challenge. So how do we then investigate it? Apart from ultrasound, a hysteroscopy or a sonohysteroscope are the two relatively low risk procedures which are very routinely used. But do we offer hysteroscopy routinely for all patients undergoing IVF? And this is the study from the INSIGHT trial, that routine pre-IVF hysteroscopy in women undergoing their first IVF treatment cycle in the presence of normal transvaginal ultrasound findings is not indicated. What about patients having recurrent implantation failure? And this is the trophy trial, again a large trial, concludes that in patients having a normal transvaginal ultrasound endometrium, hysteroscopy does not improve the live birth rate even in patients with recurrent implantation failure. So what about the non-ART scenario? Because this is a dilemma for a larger population, that when you're doing ovulation induction or an IUI, should we proceed or cancel a cycle? Again, conflicting evidences. The first paper showing that pregnancy rates are better if the endometrium is 7 millimeters or higher. The second paper showing that there is no difference. So if you look at the guidelines or the strategy, it has been shown that thin endometrium may not impact the pregnancy rates even in simple ovulation induction cycles. So with this background, now how do we go about improving the endometrial thickness? The first and the very obvious is to use a stimulation protocol which has minimal negative effect on the endometrium. And the common here is that if you're using clomiphene citrate, you could possibly change to another protocol. Some people have used tamoxifen instead of clomiphene citrate to see whether it improves the endometrium. But again, tamoxifen is not approved for fertility indication. It is only been approved for treating CA breast. The second option is not to transfer embryos in this particular cycle, but to move to the segmentation and freeze the embryos and transfer them in a subsequent cycle. The third and the obvious is to correct any intrauterine pathology. We had a beautiful talk by Dr. Gautam just before my talk that if you find intracavitary pathologies, you should correct them hysteroscopically. And apart from an anatomical benefit, there is evidence that if you have polyps or adenomyosis, correcting this also leads to improvement in the endometrial molecular expressions. So apart from a physical benefit, it also has other benefits beyond that. But what about the patients who have unexplained thin endometrium? Can we improve this by this host of empirical drugs or alternative modalities? Now, one of the commonest molecule used is aspirin. It is thought that being a vasodilator or an antiplatelet, it helps by improving the endometrial vascularity. But if you look at this Cochrane review, 22 studies, aspirin versus no treatment, this concludes that the use of empirical low-dose aspirin for the general IVF population, it cannot be recommended. If at all, it should be used only to conduct randomized control trials to see whether it produces any benefit. The second drug which is commonly used is sildenafil citrate, typically through the vaginal route. It has been thought to lead to an improvement in the PI, but again there are no large randomized control trials, and again the use of sildenafil should be considered as purely experimental. But two other procedures which are extremely commonly used, one is the instillation of granulocyte colony stimulating factor. Now this is a glycoprotein which combines growth factor and cytokine activities, and it is found in various tissues of the body. The whole story started with this publication from Norman Gleicher, Fertility Sterility 2011. What he presented was 4 patients with an inadequate endometrium. He instilled intracavitary GCSF and all 4 patients became pregnant. Remember this, Norman Gleicher, Fertility Sterility 2011. Same author, same journal, 3 years later, he published the first RCT, 141 patients, GCSF and placebo, and he himself concluded that there is no benefit at all by instilling GCSF. So the author who started this whole story has himself shown that it does not produce any benefit, and there are still a lot of people who are hitched on to this particular bandwagon. The other kid on the block is endometrial scratching. Again, this story started with this paper in 2003, that local injury to the endometrium doubles the incidence of subsequent pregnancy. I am yet to find any intervention which has doubled the pregnancy rate in any of the procedures. But this is the publication which again started the whole concept of scratching. But the moment RCT started being published, this is the first RCT 2014, that it does not result in an improvement. The second RCT, a meta-analysis, 7 RCTs, again no benefit. This is from 2019. But based on all this evidence, what is reality? And this is the reality, that in spite of all the evidences, 83% of special is recommended to patients undergoing IVF, and 92% clinicians recommended it for patients having RIF. Probably this is the most unscientific treatment that we are carrying out. And if you are a believer of scratching, you should scratch the endometrium before every embryo transfer that you carry out. It should then not be used as a one-time procedure. If one transfer fails, you scratch again and then do another transfer if you are a really believer of this. The newest addition to this is the installation of platelet-rich plasma. And today it is believed that PRP is the answer to everything. Poor endometrium, poor ovarian reserve, take the blood, separate the platelets, instill it, and it will do magic. Again, coming from this single publication. But if you look at the guidelines from society, all these procedures are still to be considered experimental, and we need further evidence before they are put into clinical practice. But let me take some time and move to another way of looking at the endometrium other than from the pure thickness, and that is from the receptivity perspective. Now, receptivity is defined as a temporary and a unique sequence of events which makes the endometrium receptive for the implantation. For majority of the menstrual cycle, the endometrium is not receptive to the endometrium. So this endometrial receptivity analysis is a test to determine the window of implantation for a patient. So typically we transfer a cleavage state day 3 embryo after 3 days of progesterone and a blastocyst after 5 days of progesterone, but this can be displaced, or this could be narrower or wider in a small subset of patients. So this is a test which tells us whether the endometrium is receptive on the day that we have scheduled our transfer. So we published in 2019, and we took 250 patients with recurrent implantation failure and carried out the receptivity analysis. We found that it is receptive in 200 and non-receptive in 50. So in nearly 20 to 25% of patients having recurrent implantation failure, the window of implantation is displaced. And now if we do a personalized embryo transfer in these patients who had a displaced endometrium, which means that you are transferring a day 5 blastocyst after 3, 4, 6 or 7 days of progesterone, you find comparable pregnancy rates. So where do we stand in terms of refractory endometrium? And if you look at this traffic light display of various strategies, you can see that other than the role of hysteroscopy, most are either effects unclear or conclude that there is no evidence. So where do we move on from here? And there are two very interesting concepts coming on. One is the role of endometrial microbes and endometritis, and second of stem cell therapy. So Semmelweis was the Hungarian physician who first started or maybe revealed the concept of puerperal fever. And what he observed, that in those days a lot of patients were delivered either by midwives or by the obstetricians. And what he found, that the maternal morbidity was higher when the consultants delivered the patients and not the midwives. And the reason was that the consultants were responsible for carrying out autopsies. The midwives were not performing autopsies. So they were possibly carrying some cadaveric particles from the autopsy room into the, when they were delivering the patients. So this whole concept of microbes, and we know that the human body contains 10-fold more microbes than human cells, and this is actually the second human genome. So the first landmark paper was by Moreno, who showed that there is existence of an endometrial microbiota which is more stabler as opposed to the normal, and this is an environment which is very lactobacillus dominant. So if the endometrium microbiome is dominant with lactobacillus, the pregnancy rates are higher in as compared to a non-lactobacillus dominant microbe. The second is the issue of endometritis, and there are plenty of publications which show that if you treat chronic endometritis, you will be able to improve the pregnancy rates. To end, a few slides on stem cells, because the uterus or the endometrium is one organ of the body which goes cyclical regeneration. Every month the endometrium is shed and a new endometrium develops, and this happens for nearly approximately 400 cycles in a woman's reproductive life. So this is the data from Professor Carlos Simon's publication on the role of stem cell. So what he mentions is that there is a specific microenvironment in which the stem cells that regulate the division grows, and in the endometrium this lies in the endothelium of the spiral arterioles, which is in the basal layer. Now if due to some pathology or due to some trauma, if this endometrial niche is broken, then the endometrial stem cells fail to regenerate, and you either have fibrosis or you have endometrial atrophy. So what you need to target is to replace these stem cells in the endothelium of the basal layer of these spiral cells. So what he did was, he mobilized the stem cells from the bone marrow. These were removed, they were isolated, and they were instilled through uterine catheterization right into the stem cells. And this is a process which takes nearly a couple of months. What he showed that the endometrial thickness increases by approximately 1.5 millimeters post this instillation. So this is stem cell instillation into the basal layer of the spiral arterioles, not a transcervical endometrial stem cell instillation. And he reported 5 live births with a 38.4% live birth rate. So to conclude, still today, conventional ultrasound is the simplest and the most efficient method to evaluate the endometrium. Newer technologies like color Doppler and 3D ultrasound help us in giving information, but their predictive value is still limited. If the endometrium is inadequate, the best strategy that we have today is to freeze the embryos and transfer them when we feel that the endometrium is better. No adjuvant has been shown to be superior to the other. Only prolonged estrogen therapy in an HRT cycle may be of benefit. We should also look at the endometrium from its receptivity perspective rather than simply a good morphology. And endometrial receptivity analysis is one such first generation tool. Techniques and procedures like GCSF, PRP or scratching should still be considered experimental till we have further proof. Stem cell therapy appears promising, but the process and the procedure has not yet been standardized. Thank you very much, and I would once again like to thank the organizers for giving me this opportunity. Thank you.
Thank you very much, Dr. Manish. That was a real good overview of a very important topic, and with all the reviews and the evidence-based
Recording
therapies.
stopped.
But ultimately, we have to apply
Recording
what our
in
patient
progress.
needs and individualize the treatment, but it should be evidence-based. Thank you very much.
Thank you.
I would like to call upon Dr. Rajpriya Ayyappan ma'am to chair the session. She is the Managing Director of Srinivas Priya Hospital, Perambur, and she is the Secretary Perambur IMA Women's Wing, and she is the Secretary Indian Fertility Society Tamil Nadu chapter. I welcome you, ma'am. And I privilege to call upon Dr. Jaideep Tang sir.
It's a privilege to be introducing Dr. Jaideep Tang. I must say it's a great afternoon, and I've been given this opportunity as a chairperson. And we all know that Sir is the President-elect FOGSI 2024-2025, and he's also the Secretary General currently of FOGSI. And he's been involved in many FOGSI projects, and he has motivated many of us to do great work. And with respect to infertility, I think he's always had a stand. He's a great orator. So without further delay, I request you to go over to the topic of the day, sir. We're looking forward to hearing from you. As they're getting the slides ready, I would also be happy to say he was conferred FRCOG in 2020 by the Royal College, and he's so far the only Indian to hold posts in local society, the Mumbai OBG Society, AOFOG and FIGO at the same time. And he's a consultant at the Ashwini Maternity and Surgical Hospital, and he's also the program director and member of board Profert IVF. He's a visiting consultant in many IVF centers. So requesting the President-elect FOGSI to start the talk.
So thank you very much for this very kind and warm and very generous introduction. Thank you. It is indeed a pleasure to be here. In fact, I must particularly thank Dr. Sanjeeva Reddy and the entire SMART team for putting such a wonderful event together. You will see that both the topics, and I hesitate to say this because even I'm a speaker, but the speakers have been selected with great care, and I'm sure that everyone who attends this conference physically and virtually will benefit from it. You might be wondering, no, this is my first slide. Yeah, you might be wondering why I am standing here in place of Dr. Jaideep Malhotra, my very dear friend and almost my eldest sister. I can rest assured it's not a mistake. Jaideep was unable to make it, and I was asked by Dr. Sanjeeva Reddy to step in, and I'm more than happy to do so. I love coming to Chennai, but the first ever AICOG I ever attended in my life was in Chennai. Of course, it was 1992, I think, when I attended my first AICOG. It was in Chennai, and after 2 days of attending the conference very enthusiastically, I actually got a little bored. So I went to the theatre, and I still remember this very vividly. I bought a ticket outside the theatre in black. It was not available, and it was not available because that movie was a Rajnikant movie which had just been released. It was called Dalpati. It was Rajnikant, Mammootty, and I bought that ticket. I sat in the stall, and I cannot tell you how wonderful that experience was of watching a Rajnikant movie in Chennai with everybody clapping and sobbing and yelling every time Rajnikant came on the screen. That experience has stayed with me, and in fact, after that, I have watched quite a few of his and Mani Ratnam sir's and even Thalapathy Vijay's movies and enjoyed them a lot. I am going to speak on choosing the right technique, right patient and right time. And in fact, this presentation is going to be something like a whistle-stop tour of so many aspects of infertility. Now, being a whistle-stop tour has a disadvantage, and that disadvantage is that I may not necessarily be able to convey the nuances of everything that I'm talking about. And I hope that if there are any nuances I'm unable to convey, you will meet me later and we can discuss these nuances. But at the end of the day, a whole lot of medicine boils down to choices. And these choices are made either by patients or by physicians. And really, this quote from Harry Potter, spoken by Albus Dumbledore in the movie, saying that it is our choices, Harry, that show what we truly are far more than our abilities. I really feel that this resonates with infertility treatment and IVF. We just heard that fantastic presentation from Dr. Manish Banker, where he talked about the fact that a whole lot of new technologies seem to have been adapted into our practice without giving due consideration to evidence. And that is somewhere we really need to take a step back and consider the evidence. And if I'm going to talk about choosing the right patient, the right technique, and the right time, which is the title of the talk, then this is the whistle stop tour I'm going to take you. And I'm very thankful they've stopped that clock. Every time Manish Bhai was speaking, I was looking at that clock and I was getting very worried because that clock kept on ticking and it was like a countdown for the presentation. So these are the topics of the whistle stop tour that I'm going to take you in terms of choosing the right patient, the right technique. And you will notice that I've left that column of time intentionally blank because I hope that that is the column I hope to fill during the course of this presentation. So let me embark by speaking a little bit on male infertility and focusing on empirical treatment first, because truth be told, in the large majority of cases of male infertility, we are in fact unable to find a cause for oligoasthenospermia. In fact, I have had this feeling for a long time that given that the large majority, and I say this very consciously, the large majority of patients who undergo assisted reproduction in fact have male infertility, it's perhaps a travesty that we don't pay more attention to it. When we talk about empirical treatment, let's always follow the principles of empiricity. Don't waste too much time or money. First, do no harm. And gauge your empirical therapy depending on the fertility potential of the couple and not the male alone. Let me explain a little what I mean by fertility potential. I mean, for example, that a patient or a couple aged 25 years old with a good AMH and severe oligoasthenospermia has to be approached very differently compared to a couple who's 36 or 37 years old with a reduced AMH and very severe oligoasthenospermia. You will obviously give a prolonged trial of empirical treatment to the younger couple and not so much of a trial to the elder couple. So although you may be looking at the same set of medical reports, the age itself reduces fertility potential. The AMH indicates that fertility potential is low and therefore do not waste too much time on empiric treatment. For patients with azoospermia, always take the help of your andrology or at least urology colleagues if you don't have andrology colleagues. The big question in these cases is always whether to do a trial surgical sperm retrieval with stimulating the female partner or first do the trial TISA or the trial surgical sperm retrieval, see whether you get sperm and then stimulate the female partner. Our approach so far in these situations has been that if we are looking at a clear-cut case of obstructive azoospermia, we stimulate the woman and do the trial, do the surgical sperm retrieval at that time. If we are looking at non-obstructive azoospermia, then we first do a trial surgical sperm retrieval, freeze the sperm if we get it, and then stimulate the patient, because in non-obstructive azoospermias, you're not always sure that you will get the sperm. The days of doing standalone biopsies by urologists and andrologists and even sometimes gynecologists should now come to a close. And I'm happy that Nandita is over here for this part because Nandita spoke on polycystic ovaries. And in my whistle-stop tour of polycystic ovaries, these are the things I want to tell you. In my clinical practice, the first thing I do when I see a patient of suspected PCOS is in fact triage them. And I triage them into non-syndromic and syndromic. And the reason I triage them is that the approach for a patient who has a metabolic syndrome and polycystic ovaries is very different compared to a patient who has no syndrome and has polycystic ovaries. After all those Amsterdam and Thessaloniki and NIH and so on, we now have this wonderful PCOS guideline published in all the journals led by Teed et al. And what they say is that the Rotterdam consensus is now firmly grounded in the best evidence. However, even within the Rotterdam consensus, there are some wonderful nuances which have come out in this guideline. And for me, this is a very, very important nuance. And the nuance is that ultrasound should not be used for the diagnosis of PCOS in those with a gynecological age of less than 8 years, that's less than 8 years after menarche, due to the high incidence of multifollicular ovaries in this life stage. I'm sure all of you have seen these very worried adolescents and even more worried mothers and fathers coming to you with ultrasound reports done for something else and saying that my daughter has PCOD, do something. But the fact of the matter is that there should not be that report saying PCOS in any girl whose gynecological age is less than 8 years. So if you consider the average age of menarche as 11, that automatically sort of takes care of almost all these patients who present as so-called PCOS right up to the age of 18 years. This diagnosis has to be completely disregarded. Further, another nuance is look at the follicle number per ovary, and you will understand that a lot of what we think is PCOS is actually multicystic ovaries or ovaries with a good fertility potential. Also look at the definition of irregular menstrual cycles, which is given in the guidelines, and of course never make a diagnosis of hirsutism or hyperandrogenism very lightly or without biochemical evidence, because it has a significant negative psychosocial impact on the girl. If you want to make a diagnosis of metabolic syndrome, you don't really have to prescribe those zillions of tests which are there in the so-called PCOS profile. What you need to prescribe are these simple 3 or 4 tests which should help you to understand whether this girl has got a metabolic syndrome or not. In this whistle-stop tour, in the remaining 11 minutes, I am now moving on to the next, which is endometrioma, because we are talking about choosing the right patient, the right technique at the right time. And the first thing I want to say is that all endometriosis or endometriomas do not need surgery. From this part of the presentation, if you take home one message, then please take home this. It is quite clear that if you do a cystectomy, compared to a simple cystotomy and then fulguration of endometriotic implant, your recurrence rate with a cystectomy is considerably lower. There is absolutely no doubt about that. However, there is also no doubt about the fact that irrespective of the expertise of the person who does the cystectomy, every time you remove an endometrioma cyst, you will invariably and inevitably reduce the ovarian reserve. And therefore, although excision may seem to be the treatment of choice, you must defer it in infertile patients where the issue of ovarian reserve is of concern. Anybody who does IVF, I'm sure, will be able to tell you of the scores of patients who have come with maybe 2 or 3 surgeries for endometriomas with an AMH so low and an ovarian response so poor that there is now no option but to offer them an egg donation. The question, of course, also arises, if you're going to leave these endometriomas alone, or if you're just going to do a cystostomy and fulgurate the area, won't that also damage ovarian reserve? The answer is it doesn't. And there is excellent evidence to show that coagulating the inside of the cyst wall, of course coagulating lightly, you can't coagulate very heavily, or doing an IVF in the presence of an endometrioma really has no effect on the outcome. A lot of times we are worried that when we puncture the endometrioma, and if that follicular fluid gets mixed with the endometrioma fluid, that endometrioma fluid will be toxic. So I'll refer you to this very nice study. There is this center in the US where they do pickups in aliquots of 60 ml. We normally do pickups in tubes of around 10 to 15 ml or 12 ml. They do pickups in aliquots of 60 ml. Inadvertent punctures of endometrioma, where the entire follicular fluid got mixed with that endometrioma fluid, those oocytes were studied and followed through their embryological course, and they found that there was absolutely no difference. So when you're looking at endometriomas, the right technique is perhaps to do a cystostomy with fulguration of the inner wall of the endometrioma, and do this in terms of time when the patient desires fertility, because the 1 year after surgery is the best time for that patient to conceive. A lot has been said about preventing OHSS, and for me, frankly speaking, this actually, the ability to substitute HCG with the GnRS trigger to trigger the final follicular maturation in an antagonist cycle, for me at least, has been the single biggest advance in IVF after ICSI. And I know that sounds a little hyperbolic, but when you consider the fact that you are almost completely eliminating one of the biggest problems of IVF, and that is ovarian hyperstimulation, by making this simple change in your protocol, I don't think that anybody will begrudge that little bit of hyperbole. In fact, that has led to this quite wonderful concept of an OHSS-free clinic by segmentation of IVF treatment, and I'm so happy to say that OHSS should ideally not be a condition which we should actually be seeing at all. This, of course, particularly in resource settings like ours, where a lot of people do batch IVF, has led to the question of how to schedule antagonist cycles. It was relatively easy to schedule agonist cycles, not so easy to schedule antagonist cycles, and there was a lot of controversy about it, particularly with the use of oral contraceptive pills. However, the two essential things in OC pill use for scheduling, one, and I know that this is controversial, minimum OC pill use of at least 15 days, and most importantly, a 7-day pill-free interval. For me, that 7-day pill-free interval between the last pill and starting stimulation has actually meant the difference between compromised pregnancy rates and pregnancy rates which would be, very good or similar to what you would get with any other kind of cycle. And that's why now the classic antagonist protocol has been replaced with a programmed antagonist protocol, where we use OC pills and look that 7-day interval is really important. And of course, those are the other ways of programming or scheduling your antagonist cycle. In the whistle stop tour again, I'll move on to mild stimulation. I'm sure this has been talked about by Dr. Nair in his presentation, but I just want to bring a perspective to mild stimulation. Is it the panacea that people think it is? Well, most certainly not. Mild stimulation does not mean that you do mild stimulation for everybody. In fact, if you go and look at the literature on mild stimulation, it's quite clear that further research is needed to clarify the controversies in this IVF approach. And in fact, Norbert Gleicher, I think Manish Bhai quoted a study from him, wrote this quite scathing article on mild stimulation, where he asked the question, who in the world would want to start 3 times as many cycles to achieve similar cumulative pregnancy rates? In fact, even one of the most ardent votaries of mild stimulation, Dr. Geeta Nargund, and this is a fairly recent publication from her unit, goes on to say that we still need more data on it, which means that one would have to agree with Colin Patrick, who says just because we can do something doesn't mean we should. Ability, quite simply, does not mean prerogative. I'll now move on to a few newer technologies. We are now looking at new gonadotropins. Long-acting gonadotropins already exist, but I must say the currently available long-acting gonadotropin does have some limitations because you need to combine it, and there is no way to modify its effect once it is given. We are, of course, awaiting the oral gonadotropins. We are looking at improving oocyte quality with new stimulation and triggering protocols, but a whole lot of them still await a whole lot of clinical validation. Newer technologies which we have adapted seamlessly into our practice, something like time-lapse imaging, for example, really have not necessarily proven their worth. And over here, frankly speaking, it's not that time-lapse imaging is bad. It is that we don't know what parameters of embryo growth to feed into the algorithm which selects the best embryo in that time-lapse imaging software to feed. Quite simply, we have not understood the morphokinetics of embryo growth as well as we should. Pre-implantation genetic screening as a way of improving outcomes in IVF has unfortunately not shown to be very useful because of various limitations, not the least of which being the way we do the cell biopsy. A lot of literature seems to suggest that this area controversy will probably not be solved in the near future, at least by our traditional cell biopsy approach, but it is possible that we could use something else which the embryo produces or which the embryo has a biopsy from to improve outcomes. Dr. Manish already talked about this, newer approaches to assess the receptivity of the endometrium, and there are some interesting things coming out, including measurement of subendometrial contractility that are hormonally responsive in their pattern and propagation, molecular tests, ERA, and of course even microfluidics. This is of course not for endometrial receptivity, this is for gauging the embryo quality. And the microbiome, I think, is really coming into its own now as something which would have a considerable impact. Lastly, I just want to say this, because we are talking about right patient, technique and time. We need to start seeing infertility as a public health problem. If you ask me, all the problems that arise from the new ART bill and the way it is drafted come because of a perception that infertility is an elitist health problem. We have not been able to drive a narrative that in fact infertility is as big a public health problem as any reproductive problem like contraception or even abortion, or if I may say so, even maternal morbidity and mortality. And this has to be our focus if we hope that policymakers, influencers and advocates of women's health pay attention to infertility more as a public health problem rather than an elitist problem. So let me end by saying on this whistle stop tour that we need to start practicing by evidence and not tradition. In fact, if you look at obstetrics and gynecology as a whole, it's not really a tale of evidence-based practice. For example, how many randomized controlled trials were done before we adopted the obstetric forceps into our practice? How many RCTs were done before admission tests and NSTs became a routine part of our obstetric practice? Hardly any. And the same seems to apply with infertility. The gold standard in reproductive medicines is to provide childless couples with the best possible management, while at the same time ensuring they are not exposed to unnecessary risks or ineffective treatments. And one of the reasons why we do more tradition-based rather than evidence-based practice is because it seems to me that a lot of our literature is more opinion than evidence. And this is so because the sample size that would be required to prove superiority is indeed massive. And if you look at the sample size that is illustrated here, you will realize that there are hardly any studies in infertility which have a sample size that is so big. So until the time comes when we insist that the generation of evidence precedes getting evidence first and then adopting it in our practice. And in fact, this author's, Dr. Bhattacharya, shows that we believe that this continuing need for medical reversal in reproductive medicine is in fact the real enemy of progress. But at the end, it's about choices, and whatever choices you make, you should be able to stand behind them. From one of my favorite TV series, Game of Thrones, is one of my favorite quotations from Ned Stark, who says, "The man who passes the sentence should swing the sword." So if you have taken a choice of patient, technique and time, you should be able to quote the evidence behind that choice and stand behind it. Thank you very much.
Dr. Jaideep Tank, I think you've covered a humongous topic, and in a nutshell, you've actually talked about who is a good practitioner of IVF. The person who knows to make the right choice for the right couple as the right intervention. And we live in a country where the patients look upon us to give the right decision.
Absolutely.
And I'm sure that in your talk, you've beautifully addressed it on time as well. So at the right time, you finished it also.
Thank you.
And first IVF baby from frozen semen sample in India. We welcome you, sir. The speaker of the session will be Dr. Vasan, sir, who will be presenting virtually. Due to some personal reasons, he couldn't make. So can you please display sir's slides?
Thank you so much for your kind words of introduction.
Welcome you, sir.
Good afternoon, everyone. And first, let me congratulate Dr. Reddy and his team for successfully finishing 10 years of Reproductive Medicine Unit at SRMC, Sri Ramachandra Medical College. I thank him for giving me the opportunity to chair this session, and now we'll be having a post-lunch session, and we will keep you awake with interesting topics and excellent speakers. The first topic will be Advances in Andrology Impacting Clinical Practice by Dr. Watson. So, andrology as a specialty, it was neglected both by the gynecologists and the urologists. Then IVF, introduction of IVF has made some interest in the field of andrology, and the invention of ICSI has revolutionized the management of male infertility. And this one, I request Dr. Watson to deliver his talk on advances in andrology and their clinical impact.
Sir, I request you to introduce Dr. S.S. Vasan,
Yeah.
sir.
Dr. Watson is the CEO and Medical Director Anku Fertility Center, and he is an acknowledged teacher and part of teaching program at Rajiv Gandhi Rajiv Gandhi University for Health Sciences. He is involved in basics research and has many patents to his credit. He is president for South Asian Society for Sexual Medicine, and he has a liberal heart and involved in charity for underprivileged cancer patients. Dr. Watson, please.
Am I visible? Am I audible? Is my screen visible?
Yes.
Is the screen visible?
Yes, Watson.
Yeah. Thank you, Dr. Sharath, and for that introduction, and thank you, Dr. Sanjeev Reddy, for this giving us this opportunity. Unfortunately, I couldn't be physically present for various reasons. I'm just going to highlight some of the practical points which will impact andrologists or people who are interested in male fertility management as we start this journey. One of the biggest challenges we have had is understanding the semen report, and we all know that by the 2010 report, which is the fifth WHO manual, we had more confusion which came into picture because of the fifth percentile value. Because gynecologists rely on semen analysis as the principal parameter to decide the fertility status of a male, the adoption of this least percentile value as a reference value, which people understood as a reference value, led more men being classified as fertile. And this created a lot of fundamental shift in the way men were managed in this last decade or so because of the fifth manual, and potentially delaying definitive diagnosis, management of infertile men, and so on and so forth. So some of the fundamental changes which happened because of this was that in the sixth manual now we have gone back to motility reporting of 4 types, which was prevalent in all other earlier manuals. And secondly, we have gone back to what is called as decision limits instead of the fifth percentile value. And also one of the things we have to realize is there is no mention of the terminology. So now we have a classification of any of the parameter on the basis of normal, borderline, or pathological, where these classifications are very well given in the WHO manual, and you could refer to that. But what it defines is that now we have 3 groups of men, one who are borderline, one who are pathological, and one who are presumably normal. So consequently, pathological we know is a pathological condition. So we are moving to a Gaussian distribution of a semen analysis reporting format. That's what has happened. Basically, because all biochemistry tests, all tests in medicine are based on Gaussian distribution, and that's what we have done. So and the second thing we need to understand is there is a fundamental shift in how do we report this? Because semen analysis, if it is not reported properly, it's a gibberish of information which the clinician fails to recognize as to what is important. So now we know semen is a multi-parameter reporting document, and it has seminal plasma abnormalities, it has sperm abnormalities, and now we have the decision limit, which is the degree of abnormality. Now, if this is reported in a very user-friendly way, just like we had an era when we used to have ultrasound reports as hyperechoic. We had Hounsfield units for CT scan reporting and so on and so forth. But now we know we want it to be cyst, we want it to be tumor, we want it to be mixed echogenicity or mixed tumor and so on. So similarly, now we have moved from reference value to a decision limit concept, and we are now potentially able to stratify fertility potential as a range, which gives a decision limit format. So now this is what has happened. As you can see in this slide, this was the 5th percentile value, where motility 42% and below was considered to be, below that was considered to be least fertile. Now, because of the fact that we have this decision limit concept, now motility, as far as motility, I'm just describing one parameter. You have a range below which motility is considered to be normal. That means if you at a 50th percentile, at a 50% motility, which is at the 15th percentile, above this is the normal range, this is the borderline range, and this is the pathological range. So that's what has happened with the new WHO format. And so this is to simplify it. So you have sperm concentration, this is the borderline range, this is the borderline range for the motility, and this is the borderline range for the normal form. So consequently, these men, it's like, upregulated and downregulated. These men could be upregulated, or you could decide whether they cannot be upregulated and they would be classified under downregulated category. And that's what is, because you're more familiar with upregulation and downregulation, I'm just mentioning. And this is the format which most of us are adopting in terms of reporting, because we need to understand that we need to give a report in a user-friendly format. So we report the seminal plasma abnormalities first, because these are correctable abnormalities and it's easy to treat these abnormalities. And if we report it in this format, then the physician will be able to see this part of the report first, and we also give impression whether there's a Possel's abnormality, RBC abnormality, is it a liquefaction abnormality. So because this is the correctable part and it should be treated first, then you have the sperm microscopic abnormalities, where we give the decision limit whether it is in pathological, borderline or normal. So it enables the clinician, and this is the final impression where we have moved away from terminology. We give you seminal fluid abnormality none, sperm abnormality decision limit, sperm concentration is whatever, pathological, borderline or normal, and we give on what basis we make this assumption. So this enables the clinician to categorize a patient and then decide whether he wants a hormonal evaluation, whether he wants a physical evaluation, whatever he wants to do, he can go ahead and proceed. So the idea is to structure the semen report in such a way that the seminal plasma abnormalities are highlighted, wherein you could QC the report, you could look at volume abnormality, pus cells, bacteria, and then treat. And then if you have the sperm abnormalities, what would be the first step? Decide which decision limit value the parameter is situated. This decides the severity of the male factor, decide the severity of the female factor, decide on the modality of treatment plan, because if there is a significant female factor, say male factor takes a secondary course of action, and decide if it can be improved, and so on and so forth. And step 3 is decide on whatever appropriate evaluation you want to ask. Now the question is, there has always been this debate, how do we manage sperm abnormalities? We know that pre-testicular causes are only 8%, post-testicular are 12%, and testicular are almost 80%. So consequently, there is a need to upgrade the fertility status of any individual, because if he is only entitled for donor insemination, if he gets a chance of surgical sperm retrieval, he can have his own biological child. So there is always a desire to increase the fertility status, because it also has a positive impact on reducing cost as well as acceptability by the patient. So male infertility management for many years was classified as specific therapy, and most of it was empiric therapy. Now we have new evidence and management of what is called as directed therapy. Now, what is directed therapy? Historically, we all know that we need testosterone and FSH, which needs to be quantitatively normal for spermatogenesis, and this is the various modalities of action of these hormones, which all of you are familiar with, and the historical concept that it requires 120 days, then 90 days for sperm production. Now we believe it is only 64 days which is required for sperm production, especially 50 days for spermatogenesis and 14 days for spermiogenesis, which is good enough. So now we are moving from initiation of sperm production to ejaculation of a new concept of 60 days. That is what it is. So this is the complex event which happens inside the testis, where we have two primary cells, which is your Sertoli cell and Leydig cell, and you have this complex interplay, hormonal interplay. So what can you manipulate? So the new concept of hormonal manipulation is what is called as amplitude and receptor manipulation. We have Sertoli cell function. We can only modify two cell functions, right? We have Sertoli cell function, we have Leydig cell function. And why do we need to modify? Because these cells may have receptor unresponsiveness, they may be damaged, they may be in a blockade mode, they may be polymorphic, it could be apoptotic, and it could have Leydig cell specifically could have Leydig cell dysfunction. Unless you manipulate, you won't know whether there is a cell dysfunction which is significant or insignificant, and which is correctable or modifiable. And the second concept of hormonal manipulation is what is called as an amplitude manipulation, where the same level of a given hormone, let's say FSH, may be sufficient to stimulate a cell in an individual A, but may not be in an individual B. The idea is to try and target response at the cellular level by varying hormonal concentration and aggressively monitor these response, as these are presumptive therapies. So now, just to simplify, I am not going to go into it much detail because I have only about 20 minutes and I intend to finish on time. So we know the normal FSH, LH and estradiol cutoff ranges. Estradiol is specifically important in male. So we believe that anything less than 4, there is a chance for receptor and amplitude manipulation, and if there is more than 8, we know 7.6 is the cutoff for non-obstructive azoospermia. Now there is no chance for a receptor or a hormonal manipulation. So similarly for LH and similarly for estradiol. So this is the group where you will manipulate irrespective of whatever this outcome is going to be, because you need to monitor the outcome. So if it is low normal FSH, that means less than 4, there is a significant impact on the sperm parameters in terms of whatever we call motility numbers being abnormal, morphology numbers being abnormal, then you give him clomiphene or HCG. If it is LH alone is abnormal, then you give him HCG. Low normal FSH and LH, you give HMG with anti-estrogen. High normal and FSH and LH, we classify them as dysgenetic testis. There can only be a marginal improvement to cryofreeze the sperm, and we give extremely low dose steroids of 2.5 to 5 milligram. So this is the classical situation where you have an FSH of 2, I've just hypothetically given situations, and you have an associated astheno or teratospermia as used to be called earlier. You could give clomiphene 25 milligram alternate days by HCG 2000, HMG 2000 twice a week, and LH is 3.2, then you can give tamoxifen 10 milligram or HCG. Instead of an irrational way of giving, we are looking at rational way of giving, and we have anastrozole in case T ratio is abnormal, and that's the way we go about it. So this is the format of the reporting, and I have just presented you a way of managing sperm abnormalities. But two specific conditions we need to remember. One is obesity. We know that there is metabolic syndrome in India for various reasons, and we know that metabolically challenged men, especially with metabolic syndrome, have significant chances of azoospermia and oligospermia, and these men response may not be as good as the normal men. And similarly, sperm in older men, especially after the age of 42, we seem to have men who have this problem. Why? Because these are the men who have evidence of faulty DNA repair and abnormal recombination. In any of these, you have leptosine, zygotine, pachytine, and diplotin, and so on and so forth. Uh, Now, so that would give you a summary of how to manage a sperm report, how it should be reported, and how do you technically take the treatment forward. What is the new way of looking at the sperm report from the plasma abnormalities and the sperm abnormalities? Now, the second challenge we have always faced as andrologists or male fertility specialists or any person dealing with infertility is non-standardization of reporting of semen. And one of the challenges was sperm transport. Sperm transport was not feasible because motility was a labile parameter which used to deteriorate over a period of time, and consequently we were unable to standardize the report. Anybody could report saying that the motility at that point in time was high and it subsequently deteriorated. Now there are buffers available. We have been working on this, and where you could transport without loss of motility for a period of 24 to 36 hours. And this will mean that you could ask the patient to courier the sample to a lab, or one X lab can collect. It's a boon for especially peripheral areas where they may not have standard this thing, and this is normal transportation with not only ice and not even liquid carbon dioxide, or it is not with liquid nitrogen. So this is just an ice shipping, not even an ice shipping. This is a standard room temperature shipping, and it retains motility for 35 hours. And this is technically feasible. This is a radical fundamental change which will make sure that semen reporting becomes more standardized, and the challenge of getting improper semen reports will be an era of the past, and that is something which is very, very useful. Now I'm going to just play in the next 5 minutes, which I have two videos. One is, we have always realized that of course there is a significant female factor which plays an important part in an IUI success, but we also do a lot of this IUI for poor sperm factor, and consequently upping the success rate in an IUI is a vital need, especially in a country like India, where the challenge is IVF accounts to only about 12 to 14% of all the ART procedures which is done in the country, and IUI is the primary procedure, and people's affordability of IUI is very high. So I'm going to present this video where, just 1 second. Anyway, I'll just summarize. I don't want to waste
that
time.
will be great. Yeah, please.
So one is the technology of using hyaluronan coated beads and stream it through a microfluidic chip, which will attract those sperms which have good hyaluronan and hopefully an intact DNA. And this is a patented product which is I think being manufactured, and at this point in time I think is also sold by Shield Healthcare. It's a technology by what's called as Achira Labs in Bangalore. So that is something which is exciting, because that will select the sperm on the basis of hyaluronan bead-based technology. And the second thing is, which is the distressing thing for most of us clinicians, is to know whether there is presence of sperm or absence of sperm in a case of azoospermia. Many a times there is a futile exercise. We depend on FSH, we depend on testicular size, none of which are precise markers, and even micro TSA has a success rate of 40 to 45%. So you have a 55% failure rate where patients go and undergo a such procedure. So a lot of groups are working on using the semen microRNA transcripts, or we have been working on the testicular microRNA transcripts, and we have just released a product which is called as ONOVA, wherein you just take a single testicular FNAC sample. Of course, it requires an FNAC sample. This is not a semen sample, and it requires 2 samples on both the sides. Has a high sensitivity of 97% and a specificity of 95% to tell you whether there is presence of sperm or not without doing an operative procedure. So these are some of the things which are exciting, which probably will aid and help the clinician further, streamline his practice and give precise counseling and precise guidance to the patients. Thank you very much, and I'm sorry for not being able to share the video.
Thank you, Dr. Vasan, for the excellent talk. Any questions, please? Yeah. Dr. Vasan, I have a question for you. Young
Sure.
man came to my clinic with the azoospermia, report of azoospermia. On examination, he has normal testes and FSS is within normal, and biopsies showed maturation arrest. Any progress in this particular direction?
No, see, the point is, if there is a maturation arrest, hypospermatogenesis, or certainly cell only syndrome, there is no medical therapy for a maturation arrest. So consequently, if there is an azoospermia, normal sized testis, so this is some form of a block at the level of spermatogenesis. The spermatogenesis is not getting complete. But there is a chance of sperm retrieval in these men, not a 100% chance. They have a 40% chance of sperm retrieval, provided they are willing to go through an IVF procedure after the sperm retrieval, because the sperm can only be used in an IVF procedure. So one is the counseling angle, that you would counsel them on the cost implication of both a micro-TCA in your center and an IVF, and also the success rate. And if he opts for it, that is the way to go. Otherwise, the second option is to go for a donor sperm, because that becomes simpler, where he doesn't have to spend any money. Third option is whether nowadays people are looking at stem cell, and the stem cell which seems to work in this kind of an instance is bone marrow stem cell, mesenchymal stem cell, but still it's very early days. Results are inconsistent. Few people have reported some success, but everybody will not be able to replicate the success. So there are challenges, and it's also a costly procedure at this point.
But the second procedure which you said, no, that one will it be of use for this particular group of patients to find out whether there will be any sperms will be available or not?
Which procedure you are talking about? Micro-TCA? Stem cell?
No, the second procedure which you said, no, previously.
No, there are only three ways. One is either offer a fine needle aspiration. Failing that, they go for it, because sometimes you can find sperm by a fine needle aspiration. It's always wise to put in 4 to 5 places fine needle aspiration. If you get sperm, you end the procedure instead of trying to make a cut. Otherwise, you convert it to a micro-TCA if the patient has given consent. The second is only going for a donor sperm, and third is only a stem cell.
Thank you.
Was in some cases I tried this maturation arrest patient. It came as maturation arrest with clomiphene citrate and HCG. Some patients, after 3 months of treatment, they are developing sperms.
Yes, sir. This is the late maturation arrest. This might be a late maturation arrest. If you are able to get late maturation arrest, yes, there is a role of some people trying this hormonal therapy, but the success rate is supposed to be only 6 to 8% of men. You seem to be very lucky, or your strategy seems to have worked very well. One of the fundamental criteria for trying even in these men is the testis size should be more than 12 cc. Most of the Indian testises do not come up to 12 cc. They are usually in the range of 8 to 12 cc, sometimes less than 12 cc. So people who have a good size testis seems to respond better. Again, the challenge is the cost and the uncertainty whether they will find sperm or no sperm at the end of the trip.
So if there are no questions, then we can conclude this session. Thank you, Dr. Vasan. Thank you so much.
Thank you. And thank you, Dr. Reddy, for the talk.
I thank Dr. Reddy once again for giving me this opportunity, and I wish him will go for the Silver Jubilee. Yeah. This is the 10th anniversary, so we'll all meet once again for Silver Jubilee. Dr. Reddy, we wish you good luck.